I appreciate you all coming. Over the next 15 hours, we're going to throw at you a lot of stuff. Some of it is going to be controversial. Some of it you will not agree with. That's okay. We just need to try to move our departments and communicate to each other ways that we think that will work, that have worked, that have not worked, things so that there's a lot of experience in this room. So the idea is to cross-pollinate each other, intellectually at least, here in Las Vegas regarding how. Thank you very much. I don't know. All right, let's get started. So I'm in Los Angeles. I'm the medical director of a 25,000 visit year emergency department. But I believe that everything that happens in a 25 is basically half of what happens in a 50 and a quarter of what happens in 100. And that what I'm going to suggest, I think, is very scalable. Those of you know, maybe, Emergency Medical Abstract started in 1977, review 600 journals a month, and about 4,000 docs we give them a clinical update monthly. Jerry Hoff, myself, been doing that for a while. Somehow I got on a clinical professorship. I have no idea how that happened. But my love is the idea of working in an emergency department and trying to make it as good as we can with all the challenges that we're dealing with. This is our litany of whining. We've gotten real good at this. We've gotten real good at complaining. We got the unfunded mandate here. We even made a new word. I don't think you'll find this word in the dictionary, overcrowding. We'll tolerate crowding, but we draw the line at overcrowding. There's no. Long waits. We're the only business nationally, when you think about what people say, they say you have to wait a long time to be seen in the ER. Where were we here? Oh, long waits. You ask anybody in the community, they're going to tell you, go to ER, you have to wait a long time. Now, some of you may not have them wait as long as others, but this is a national reputation of our dysfunctional businesses. And so we have a lot of low-hanging fruit, I think, in terms of making ourselves better. Oftentimes, the patient is perceived as the enemy. Weren't you here last week? That's not what they say when you go to a restaurant here. Are you hungry again? Didn't you eat last week? You're a McDonald's abuser, coming time and time again kind of thing. Patient satisfaction, all the CEOs, they're driven by this. They're driven by it. It means a lot to them. I think a lot of their bonuses are determined by the patient satisfaction kind of thing. So this is disproportionately important to them. We hold all these admitted patients in the emergency department, and therefore we're doing floor work. We admit a patient, and 2.5 or 3 hours later, they leave the department, and your nurses are doing admission orders, antibiotics, all of these other kinds of things for these patients. It really should be done on the floor. Inadequate staffing, most of us are going to say that this is an ongoing issue. The suits basically say you're overstaffed. We say we're understaffed. And so there's always this tension between us about this. And we'll talk about that in a bit. Surge capacity, what the heck is that? We have no surge capacity where I work. We are full out all the time. This is the best we can do. And if there's a national disaster or something like that, we're going home. We're not sticking around there, no way. And then there's always, oh, we don't have enough money. There's all this, we're poor. I'm going to show you just the opposite, that most of the hospitals we're talking about, community hospitals, are not poor at all. Now, there's a wide spectrum of hospitals, and some of you are providing services to the community that nobody else wants to provide. You're the hospital for the indigent. They're the hospital of last resort. That's where you go. And your bills are generally paid for by the taxpayers. At our community hospital, we make money by the people who come and pay us. But most hospitals are like that. They're not necessarily hospitals where the poor preferentially have to go. And I have no idea why anybody would go to one of those big municipal hospitals where I have to wait 6 or 8 hours, when you can go to my hospital and you'll be seen in 30 minutes because EMTALA says we're going to see you anyway. So why would you possibly go to Los Angeles County Medical Center where you have to wait? It's like Darwinian triage there. Us versus them. There's this tension, I believe. Why doesn't the administration get it? Can't they see we need some more help? Can't they give us more resources? Any not that you would admit it right now, any COOs in the room or any administrators? Yeah, nobody's going to admit it after I gave that great introduction. But the fact is, there is this perceived tension between us. We should all be on the same page. Aren't our goals the same? Aren't our goals to see as many patients as we can, do a good job as we can, get them in and out quickly, make them satisfied, make the medical staff satisfied? Our goals and their goals are really very much in tune. So what's the story? What's the problem, and how can we fix it? Well, I believe that one of the ways you fix it is that you have to talk their language. They want an ED that's profitable. When they go to CEO school, they're taught ERs are losers. How could you possibly be a loser? Jim said 64% of your patients come in through the emergency department. How could you no ER, no admissions? And I'm going to show you some of the numbers in terms of the profitability of community hospitals, and I'm going to ask you some of you about your numbers. They want an ED that satisfies their patients, and we want the same thing. We want happy people who go out and say, I was great there, next time I'm going to come to your hospital. Because in Los Angeles, there's a lot of emergency departments, and they can choose to go that one or this one or that one. Some of you, you're the only hospital in town. And the nice thing about that is you can be as mean as possible, and they have no choice, but they have to go back to you. In Los Angeles, there's one in 2 or 3 or 5 miles in any direction that they can go to. So we want to be the ER of choice for the region. And it's not too difficult to do that because the other places are so dysfunctional. They don't value your privacy, they make you wait, etc. So that we want to basically be the place they want to go. And the medical staff is our customer too. They want the medical staff to be happy. Send your patient to Dr. So-and-so, we'll work them up, we'll give you a call. You can see them in the office tomorrow, those kinds of things. That's what they're looking for. They want the ER to help them out in their tough cases. The suits want desirable inpatients. They're not looking for necessarily the charity cases, but we are a big source of their admissions. And they don't want to be bothered by us. The ideal ER is one where they don't hear from us. It's running like a top. We're not asking them for anything, and they can focus on their other problems. So they don't want you to be, a source of their grief in their life. They have enough of it. So here are the myths. ERs lose money. That's not true in the majority of ERs. When I say majority, I mean the vast majority of ERs. The new number, 65% of admitted patients come through the ER. The ER is the only department at a hospital, think of this, that can determine its own financial destiny. You provide good service, you get them in and out quickly, they're going to say, I'm going to come back to that place. The GI lab can't determine its own destiny. The GI doctors are the ones who drive patients into the GI lab. The ICU doesn't control its own destiny economically. You're dependent on the medical staff. The operating room doesn't. We're the only department of the hospital that says our success can be created by our behavior. And so what we're looking for is good, fast service. This idea we need to cut costs, this is a mistake. It's really a mistake. Actually, cutting costs may be disproportionately decrease your revenue. And we have to talk about revenue. Most people only know costs. And those of you who are nurse managers in your department, you know what you spend. You know what the cost is for the clerks and the techs and the secretaries and all of those people that are underneath you. You get to see what the bills are for their labor. What you don't get to see, and I would be surprised, maybe some of you do, you don't get to see anything about income. Whoever talks about cost, and not about, what's the revenue? What are we bringing in? What's the patient worth? So I would ask you, and well, hold off on the question, but it's not fair just to talk about what your costs are without knowing what your revenues are. And your revenues are going to be surprisingly high, surprisingly high. So we need to talk their language. We need to adopt their goals. Our goals are their goals, really. We need to adopt a business-like approach so that we can make a case to them about why this ER needs to be good, great, excellent, and better than all the others. And it's a business case. It's not about medicine. It's not about being nice to the community. It's about generating dollars. It's about generating dollars. And the ERs that are good at generating dollars generally are the ones that are meeting the patient's expectations. They're getting them through quickly. They understand all of the expectations that patients have, and they're trying to deliver. So we need to make this compelling case. And And our goals need to be embraced, their goals. Your goal, you want more patients, you want more surgeries, you want elected more admissions. That's the same thing we want. You need to know some information. There's 3 bullets there that you must absolutely know, and I doubt, frankly, whether most of you know the most important one of the 3. What does your hospital collect for every patient who is discharged home from the ER? Can I see your hands about who knows that number? What is your number? $183. Is collected for every patient who goes home, not on the doctor side, the hospital side, facility side. $97. Anybody else? Help me out here, guys. Help me out here. No, we want to know the average collection per patient who goes home. Who said 400? There you go, there you go, there you go. Now we're getting to more serious numbers here. Anybody else? Well, our number was in the neighborhood of $400 per patient. Community hospital, and I'll show you our payer mix. It's not a great payer mix, and then basically that was the number. It's not the most recent number. It was the number. What does your hospital collect for every patient who arrives by ambulance and arrives by ambulance? You need to know that because some hospitals have the ability to close ambulance traffic because they're too busy, too saturated, too whatever. And you need to know the financial consequences of closing to ambulance traffic. And then you need to know your staffing cost per patient, which every nurse manager in this room knows, don't you? I mean, this is what we divide our number. Here's our patients, and this is what we spent, and we divide them, and we're spending X dollars per patient on staffing, and you got to get that number down. It's too high. Whatever it is, it's too high. I believe financial data can be used to answer all of these questions. You say, we don't have a good payer mix, we need a new EMR, we need more nurses, who will pay for the scribes, the lab is too slow, the ER can't be holding these admitted patients, the E needs to close the ambulance traffic. Every one of these is a financial question. It's not really about what it appears to be. So here's the question, do you want more patients or less patients? That's the fundamental question. Do you want more business or less business? And the fact of the matter is if you look how we behave as if we want less business. We have a big, huge waiting room. Do you know of any other businesses that have a big waiting room like that? You go in to buy a car, here, sit in the waiting room, we'll be with you in about an hour after you get triaged. These are people bringing dollars for service, and yet we kind of think we're doing them a favor. We have the reputation for making patients wait. We have large waiting rooms. I was at Eisenhower Hospital in Palm Springs. Huge waiting room, big, expensive saltwater fish tanks. That's what you brag about. What you should brag about is having no waiting room. No waiting room. That's what you should brag about. We don't seem to value patients' time. You know, they're there forever, it appears. We don't value their privacy. We're seeing them in the hallways, no gown to cover their tush. And we don't look like we're treating them like we're glad to see you. Can't they see we're really busy? We'll get to you as soon as we can. Come on, give me a break now. This is often the verbal or the nonverbal message. How many times do you see patients come in and you see the staff roll their eyes? And like, uh-oh, another back pain, drug seeker. Labeled right off the get-go. I have a woman who works with us, does our schedule. She was admitted to the hospital about a week ago with recurrent kidney stones. She's had them a bunch of times. Her urologist would not discharge her on any triplicate medication. And the more she asked, the more he suggested that she's a drug seeker. She got 2 kidney stones shown on the CAT scan, black and white evidence, and she's being accused of being a drug seeker. I mean, this is not good. This is not good. This is our old data. This is our old data, and Brett, it goes along with you, $400. I have new data from a week ago, and I found this data unbelievable. And so I didn't want to put it here, but I want to tell you what our administration believes this is true. Our administration believes that they collect, on average, $749 for every patient that goes home. $749 for every patient that goes home. I've done this a lot, and I've asked other people who know their number, and I can tell you the numbers tend to be $400 or $500 is routine money collected on average for patients who go home. This is all, after all said and done. These are huge numbers, huge numbers. And the fact of the matter is you really need to know these numbers because the equation is costs versus revenue. And you have no idea what your revenues are. And until you know the value of a patient, and the fact is that you had a left without seen rate of 3%, and every one of those patients who left without being seen was $400, and that you need to fix that because there's an opportunity here. So the answer is we want unequivocally more patients. We'll never say, are you here again? Because the fact is that they were bringing a number like that, and they're bringing a number like that, and they were bringing your number. You just need to know what it is. And the way you get the numbers, you ask the CFO, because they won't trust anything that you come up with. So that number has to be generated by them because they have to believe it. Because you're going to use this number to get some stuff that you want. So anything that gets in the way of getting and treating more patients is bad. So this is going to all be about now throughput, throughput, throughput. It's all about throughput. So I'm going to give you some financial data. This is our hospital. And I put it up here just to show you that it's no big deal in terms of it's not special. 30% Medicaid patients. And 11, so that we got 40% cash and Medicaid. So certainly not an exemplary payer mix. What does the ER team generate per patient? Well, say for the sake of discussion, the doctors get $100 per patient and the hospital gets $400 per patient. So every patient who comes in is worth $500. $500. We see 2.72 patients an hour. In 2008, when the last time I put this together was 2.7, which is pretty moving. And so you start doing some little math here and multiply 500 by 2.7 times 24. And the fact of the matter is that in an hour we're generating $1,360, which is $23 a minute. The doctor and nurse team at our hospital is generating $23 a minute. And I dare say that many of your hospitals, you're generating more than that, or maybe a little bit less, but that's the neighborhood. So that whenever you're talking about encumbering doctors and encumbering nurses in terms of their ability to see patients, just convert it to $23 a minute. If it takes me more time to chart because I have to do an electronic medical record, it is $23 a minute for me to chart because I could otherwise be seeing another patient. And the assumption here is that your ERs are busy and that you have opportunities to see other patients. So the revenue for the hospital in an hour, just taking their $400 is $18 a minute. This is some of our RVU when per patient and per hour. So what are our costs? At our hospital, this is current data, it costs $170 in labor charges to see one patient. $170 in labor charges, and we generate $400. $174, it sounds like a good deal to me, especially if I can see them in 2.5 hours or 2 hours. This is easily found. It comes from the nurses. They have all of this information. There are other labor charges. It's not just your nurses and techs in the department. So there's the x-ray people and some administration and housekeeping and the IT department and the people who answer the phones in the basement. So we'll have to acknowledge that they're also part of their salaries have to go into this as well, and we'll talk about that. Labor costs are clearly the most expensive thing in a hospital, 70% really. If you don't know income, all you can focus on is expenses. And I basically say, yes, we know our expenses really well, but we don't know our income, and that's why we have to do this exercise. This is an exercise that each of you should do. So we got $400 collected by the hospital. We saw 62 patients a day. That's $25,000 a day. You know very many businesses that generate $25,000 a day in revenue. This is a community ER, no big deal. The salaries, we added up all those salaries. There were $11,000. And let's throw in some other salaries. Let's throw in another 50% for other people, like other labor costs in other places in the hospital, and throw in a little overhead. So we'll throw in 5,000 to the 11,000. So now we're talking about what is our net revenue? We're going to make if we do 11,000, we're going to make $2,500 a day. $2,500 a day. There's two projections here. One says I will take 50% of my 11,000 and say that's the extra work that we have to pay other employees. Or I'll even double it and I'll say we're going to take $22,000 in labor costs, 11,000 direct costs in the ER, and another 11,000 from all of the other people and the CEOs and that kind of thing. But here's the kind of revenue and profit. This is gross profit, $3 million at our hospital. $3 million at this little emergency department, 62 patients a day, $3 million. And if you double the labor costs, you're making them $1 million. And look at the marginal income. So if you could see 5 more patients a day, at this emergency department. 5 more patients a day at $400 for the hospital. That's $730,000. So you add that 730 to 3 million. That's 3.7 million. You add it to 900,000. It's $1.6 million. You have a huge money-making business in most community hospitals. And the idea is more patients. It's more patients. 5 more patients. You think you can see 5 more patients in your emergency department without even adding 1 bit more staff? Absolutely, and proportionally to what I'm talking about here. Ambulances, we see a half a patient an hour. They bring 1 half in the first hour, and then the other half of the patient comes to rise in the second hour, you know? And then at the end of 2 hours, we have 1 whole patient. The admit rate for ambulance patients at our hospital is 47%. How much does your hospital generate on an ambulance case? Well, figure 4, 6, or 8,000. It's in that neighborhood. That means for every hour that our ER is closed to ambulance traffic, it is costing the administration of that hospital a minimum of $1,000, $1,400, almost $2,000, depending on what you think an admitted patient generates. We cannot close to ambulance traffic. They think it's important not to close to ambulance traffic. This is the reason it's important. Well, plus the medical staff doesn't want their patients taken to some other hospital that they don't go to. They'd rather have them come to your hospital. So if you can convert closing to ambulance traffic to dollars, and if you can convert, left without being seen to dollars, then basically maybe you will catch their ear about why we have to fix these problems. Left without being seen. So Catholic Healthcare West, our hospital was a member of Catholic Healthcare West for many years, and that's 42 hospitals. In fact, University Hospital here, they have a couple of other hospitals here in Las Vegas. So the system of 42 hospitals at a 3.3% left without being seen rate. The worst hospital was 6%. 6%, 1 out of 16 people left without being seen. Our data, this is where we were in 2006. We were in the top 4, got worse. There's a reason for that. I bet you for the 2009, we will be about 0.6 again. That's like 6.6%. What is the average? That was 3%. This is 3% of 1.2 million visits. There's 40,000 patients left without being seen in this system's hospitals. Are they worth $300 a patient? Minimum. So what is left without being seen in terms of an economic challenge for Catholic Healthcare West? It's $12 million. Minimum $12 million. You have to quantify the magnitude of these problems in a manner that the CEOs and all those people will kind of light up to. You have 2 options. You can build a bigger ER. It's going to take you 5 years. It's going to cost a lot of money. And there's a great report. We built a bigger ER, and our length of stay didn't get any quicker. You have to work at that, Or you can see patients faster. We're talking about number 2. This is the way to fix your problems. We're going to see more patients. We're going to see them faster. They're going to make them happy. We're not going to have them complaining. They're going to get in and out. They're going to tell their friends. We're going to see them faster. It's not very costly to do it. You can change your modus operandi in a week or 2 after you get back home. The crippler of ER performance is progressively increasing length of stay. So you must know your length of stay numbers. You must know them. And there's 2 numbers, the length of stay for discharged patients and the length of stay for admitted patients. The ER doctors and nurses are probably a big determinant of the time for length of stay for discharged patients. They're not very good. There's other factors on admitted patients. We'll talk about those. So here's the service goals, 2 hours. We want a discharged patient from time in to time out in 2 hours. That's it, 2 hours. Is that a feasible goal? Absolutely, absolutely. I want an admitted patient admitted in 3.5 hours. And people say, that is impossible. It's not impossible. This became, the system goal for CHW was 2 hours for, now do you know what your numbers, do any of you have any numbers? Discharged patient throughput time.
Discharged hour and 20 minutes, and admitted is about 3 hours.
That's superb. Superb. An hour and 20 minutes for a discharged patient.
Yeah, we're doing 35,000 and 14 bed ED, so we're still back up.
I was going to say 35,000 and 14 beds. Is anybody seeing these patients you're sending home? Just go in and just go fill out the paperwork and out the back door kind of thing, Because the point is, for those of you who have 3 and 4 hour lengths of stay, that there's people in this room who can beat you badly. can beat you badly in terms of their throughput. Some data from CHW, discharged patients. This was their average. They did a 1-week time study. Every year, for 1 week, every one of their hospitals, they collected data that was then added up. So this was their data from 2006. The average discharged patient was 3 hours, 3.3 hours. Not good. This was the worst, 5.6 hours, abysmal. At that time, we were 2.3. Admitted patients, we're holding for a bed, those kinds of things. The system average was 5.5. This is remarkable. This one hospital, during that 1 week, the average length of stay for admitted patients was 11 hours. By the time 11 hours is up, you can send them home. The disease is over. The pneumonia is cured. The CHF is better. Why put them in the hospital anymore? You know, this is horrible, absolutely horrible. And we were a little bit less. But you know, people get used to these times. They kind of think, it's always been this way. This is what we're used to. So this is door to provider time. So in 2004, it was 6 minutes for us. Arrival to doctor was 26 minutes. 26 minutes to the doctor. In 2005, it got worse. But we were not bad when you look at CHW for 2004. It's 70 minutes from the time they clock into the time they saw a doctor, an hour and 10 minutes. And they got worse with time. Arrival to discharge, that was 2 hours. In 2004, it's 2.5. But this is 3 hours. The whole system of all of these hospitals, they're all doing poorly. They're all doing poorly. But they just don't know it. They don't know what the exemplars are. Nobody's driving them to get these patients in and out quicker. This is the length of stay for admitted and discharged patients over time. I'm not really proud of this. This shows our systematic deterioration. But it also said in the year 2000, our average length of stay was 2 hours for a discharged patient and 3.5 hours for an admitted patient. The goal that we were shooting for, and I think that is reasonable for you to shoot for, is 2 hours for a discharged patient, 3.5 hours for admitted. In 2009, we're around 2.5 hours. Not great, not exemplary, but it's probably hours ahead of some of your ERs, hours. And the longer they're there, the more they want you to do. Can I have a drink? When's lunch? Walk me to the bathroom. You know, there's more of these assessments got to be done, more nursing documentation. This is length of stay for admitted and discharged patients by month. Our hospital was bought by a new company in end of December, and for 3 months we were in a terrible mess. A whole new computer system, but after we got back to improved over time. Average door to provider. This is measured by doctor at our place. I can tell you our doctor's average door to provider time. And we're talking about averages. Now, Jim would say the more proper term to use would be the median. So median means half are less and half are more than a certain time. This is the average. And so the median is more charitable, isn't that, Jim? The median is much more charitable. Yeah, so that you have somebody who's waited a really long time, they disproportionately pull this number up from where you want to be. So you could say perhaps 70% of our patients or 80% are seen within 30 minutes of their clock-in time. Not their bedtime, not their disposition time, of their clock-in time. And I mentioned earlier today, triage is a total waste of time. I don't want to do it. Triage is no beds, we'll do triage. But we want to have beds open so we can get onto these people. You'll never get a 30-minute door to doctor time if you do triage. Won't happen unless you're doing this accelerated triage where you're taking the 6-minute triage kind of thing. Keys to improving turnaround. All of our doctors and nurses know our service goals. They all know them. I send to our doctors, here's your door to provider time, doctor, compared to your. So we have some doctors that are slugs. It's like they don't get it kind of thing. We have others that are exemplary. If you show doctors the data, they do not want to be outliers. They do not want to be on the edge of the bell. So if you show them that this doctor is averaging 51 minutes and this doctor is averaging 25, it's like, doctor, don't you want to play? This is the goal. So you have to show them the data. Doctors are really good at disputing the data. So you have to give them the data of not just 1 week or 2 days. You got to give them large amounts of data so that they cannot criticize the data. No triage when beds are empty. They come straight back. They come back the way the CEO's wife comes back. You think anybody important goes to the window and says, I'd like to be seen here? Do you think they go through triage? No. There's a separate system for that. Come with me. That's the system we want for everybody. We don't make a distinction here. Rapid lab, yeah, we're going to talk about those things in more detail as we go. So here's the summary. You need to make a financial case to the high seas about why you need to make your emergency department better. A case that is not driven on the quality of the medicine, because they're going to assume that you're doing decent medicine. So this is about throughput, happy patients, more volume, increased marginal revenue. It's imperative to get there. This is top down. You will, if they want you to create a really cool ER, they will give you the resources to do it. If you have to beg them from the bottom up, oh, please give us better lab time, please give us better x-ray time, we need the ultrasound tech here quicker at night, that's a really painful way to go. If the COO says, I want to have the best ER in the area, it will happen. It will happen. And it won't cost a lot, and the fact is they will make more money than they make now. You can't let them get away with saying ERs are losers. It's just not true. Virtually all the problems associated with dysfunctional ERs, which I believe most ERs in this country are dysfunctional, frankly, because if you look at your wait times, unless you have really good door-to-provider times, you're making people wait 45 minutes, an hour to be seen on average. No good, no good. No other service business will do that, make a person wait an hour. You get $400 from them, and they're there for some period of time. I mean, you can stay at this hotel for 24 hours for less than $200. Your ER is making $400 or $300 in 2 hours or 3 hours. No business is generating that kind of revenue. So it has to be looked upon as in a much more positive way than, and if you view this as positive, we'll just be even better if we see more, faster, more and faster. That's the key words, more and faster. And we're going to give you over the next day and a half a whole bunch of techniques to be more and faster.